Hello, folks on Zoom. I'm just getting everything up and running. Ready? All right, so today we're going to start talking about PTSD and stress-related disorders. Heads up that if you are someone who has struggled with PTSD or trauma in general yourself, there's a possibility that something we talk about could be triggering for you, and just take care of yourself, do what you need to do in order to be mentally safe and secure. I'm just taking attendance real quick, and then we will dive on in, making sure I get everybody in Zoom. Okay. And then person real quick. All righty. Okay. So these are linked to anxiety disorders, and in fact, just like OCD, once upon a time, PTSD and some of these stressor-related disorders were classified as anxiety disorders, but they now have their own category in the DSM-5. So first, we'll just talk about stress. We're going to talk about stress-related disorder. We got to think about what the psychological definition of that is. So a stressor is just an event creating demands. An event creating demands. And the stress response is how we react to those demands. So our reaction to those demands. And our stress response is influenced by a bunch of different things, including how we appraise both the stressor, the event itself, and how we appraise our capacity to react to the stressor effectively. So if we think, I got this, this is a stressor, but I got it. That's very different than if we think, there's no way I can handle this. One of the things that always surprises people when I talk about this is eustress is the thing, and that's positive stress. Eustress includes things like planning a wedding or other big party, right? It can be a really great, fun event. It could still be really stressful, right? I remember, I don't know, like a month out from my wedding, my father was like, you need chair covers. And I was like, what? My mom was like, this is the one thing he wants. Can you get it? So I frantically found a place that could do chair covers for us, right? And the wedding itself was great, but all those little things were eustress for sure. And then distress is what we typically think of when we think of stress. It's negative stress. So fear itself is a package of physical, emotional, and cognitive responses, and often to particular stressors. And we've talked already about the fight or flight response. So this is involved in both anxiety and these stress disorders. And it can be really adaptive. It's an inherited tendency to defend or protect oneself in the face of danger. But it's overactive in stress disorders, just as it is in things like panic disorder. Your book goes into a lot of detail about the biology of this response. I'm not gonna text you guys on that, so, just sort of skim it. So now we're gonna start talking about the psychological stress disorders themselves. And in particular, the stressors we're gonna talk about now, we would call traumas or traumatic events. And during and immediately after a traumatic event, many people become highly anxious and or depressed. And for some, these feelings will persist well after the trauma, and these are folks who might be diagnosed with a stress disorder. The precipitating event usually involves actual or threatened serious injury or death to self or others. Actual or threatened. So the two main stress disorders we tend to think about are acute stress disorder and post-traumatic stress disorder. And these are diagnosed in individuals who experience a trauma and show lasting effects. Acute stress is where your symptoms begin within 4 weeks of the event, the trauma, and last for less than a month. Now, in theory, you could initially be diagnosed with acute stress disorder and then continue to have those symptoms, and then you would be diagnosed with post-traumatic stress disorder or PTSD. But with PTSD, the symptoms don't have to begin within those first 4 weeks. They can begin anytime after the traumatic event. But they have to last longer than a month to be diagnosed with PTSD. About 80% of folks who do have acute stress disorder go on to develop post-traumatic stress disorder. So these are the symptoms, and just give you all a heads up. This is one of the most complex set of symptoms of any psychological disorder. This in the past, disorders like this have been called like the menu disorders, where it's like you need to order something from this side of the menu and 2 things from this column of the menu and things along those lines. So again, acute stress disorder is going to have most of the same symptoms. They're just going to be of shorter duration. So you have to have what we call a criterion A event. So it's exposure to actual or threatened death, serious injury, and or sexual violence. And the sexual violence clarification is new to the DSM. Again, it's like 10 years old now, so it's not that new. But certainly for years and years and years, they didn't specify that sexual violence was one of these. And you can experience it in a host of ways. So you can directly experience it yourself, have it happen to you. You yourself are seriously injured or threatened with death. You can witness it happen to someone else in person, right? So you watch one of your fellow comrades in war step on an IED and blow up, right? Horrifying. You can also learn that the traumatic events occurred to a close family member or close friend. In that case, it's violent or accidental. And then experiencing repeated or extreme exposure to adverse details of the traumatic events. And this typically does not include exposure through social media, TV, movies, things along those lines, except if it's work related. So for example, I think it was a Navy vet that I saw at the VA while I was on my internship year. And his job in Iraq had been to sit in a tent all day with a wall of TVs in front of him and watch everybody's helmet cam footage. So he watched raids, he watched market bombings, right? So because he was required to do that for work, he would actually count. Although at the time, I think I saw him in 2010, we kind of had to be like, well, we think this counts because there wasn't explicitly explained at that point in time. So you've got to have a criterion A event, otherwise it's not PTSD. Then you have to have a presence of one or more of the following intrusive symptoms associated with the trauma that begin after the trauma occurred. So recurrent, involuntary, and intrusive distressing memories. They kind of feel like they come out of the blue for folks. recurrent distressing dreams, nightmares related to the trauma. Probably the hallmark symptom that a lot of people think of are dissociative reactions or flashbacks, in which the individual feels or acts as if the trauma was reoccurring. So for Vietnam era vets, a car backfires, they hit the deck. Because to them, that sounds like gunfire. For some of our OEF, OIF, Iraq and Afghanistan vets, they'll start driving in the middle of the road because that's what they had to do to avoid the IEDs. It's great if you're the only car on the road, not so great if you're like going down I-264 at rush hour, right? I had a client who had been sexually assaulted. That was her trauma. She'd be having consensual sex with her husband and have a flashback and feel like she was getting sexually assaulted again. So these can be very intrusive. You might also have intense or prolonged psychological distress at any exposure to internal or external cues that remind you of the trauma. So I had a vet who had out-processed from the Army, but still worked for them civil service. And he would leave the room whenever someone mentioned the war in Iraq. That was really interfering with his work because he worked for the Army, right? So very problematic. And there's marked physiological reactions to reminders of the trauma, and these can look like panic attacks, have very similar symptoms. And so those are your criterion B, or what's listed here as 2 symptoms. So these intrusive symptoms. Next are avoidance symptoms, so persistent avoidance of stimuli associated with the trauma beginning after the trauma, as evidenced by one or both of the following. So this was my client who left the room, right? Avoidance of distressing memories, thoughts, or feelings about the trauma, and avoidance of external reminders. And these can be people, places, activities, situations, conversations. So maybe you went to war with all your best friends from high school, and now you can't be around them because it brings up your PTSD symptoms. So now you're even more socially isolated. So avoidance of any of these external reminders that bring up distressing memories, thoughts, or feelings about the trauma. So then the next set are the changes in cognition and moods. These are negative alterations in thoughts and emotions associated with the trauma, beginning or worsening after the trauma. They have that worsening to recognize that some people who experience trauma might have already had depression, for example. And you have to have at least 2 of these. Inability to remember an important aspect of the trauma. And this is actually biologically based. It's something your brain does to try to protect you. Persistent negative beliefs or expectations about oneself, others, and the world. So sounds very similar to depression, right? But this is more often about feeling unsafe. Persistent distorted cognitions about the cause or consequences of the trauma that leads the individual to blame themselves most often for the trauma, or sometimes others. Persistent negative emotional states, so feeling fear, horror, anger, guilt, shame, some combination of those. Anhedonia, what we talked about with depression, just not wanting to do activities you normally enjoy. Feelings of detachment or estrangement from others. And persistent inability to experience positive emotions. So watching a really funny comedy and you just can't bring yourself to laugh. Marked changes or alterations in arousal and reactivity associated with the trauma, beginning or worsening after the trauma. And again, you need 2 or more of these. So irritable behavior and angry outbursts, reckless or self-destructive behavior. So this could include self-harm, but more often includes self-medicating with alcohol, drugs, things along those lines. Hypervigilance, being always on your guard, always looking out. A lot of, especially war vets, but also like active or veteran law enforcement officials, if they came into this room they would sit in one of these two corners. Because then no one could sneak up on them, they can see everybody coming into the room, they can monitor it. I had a client who, in addition to PTSD and traumatic brain injuries, mostly from the IEDs, one of the other signature injuries we see in these OIF vets is knee and back injuries, because they would carry around about 100 pounds a year. And so this vet had knee problems. He had a property that was a couple acres, and he would still patrol his property every night, even though it was physically painful for him to do so, because that was part of his hypervigilance. If you do sneak up on them, they have what's called an exaggerated startle response, jump a mile. A friend of mine on internship saw a vet who, when his kiddo woke him up, didn't know where he was, thought it was an enemy combatant, grabbed his kid by the throat. Kid was okay, not physically harmed, obviously shaken up. And so they had to like explain, like, you can't wake daddy up while he's sleeping. So again, can be very difficult. They can have problems concentrating and also sleep disturbance in general, a lot of insomnia. Again, it has to last at least a month. And then there's clinically significant distress or impairment. And for some veterans, this is very hard. They would talk about like only being able to go to Walmart. There was a 24-hour Walmart, only being able to go at like certain times of night when there weren't a lot of people. Because like if they came around the corner and someone was there and scared them, they would have symptoms. All right, so I have a brief video of people talking about what it's like to live with PTSD.
It's like living with a leash on a little bit. You can do some stuff, but every now and then you remember that it's there.
I was living in Japan during the earthquake in 2011.
A few weeks and months of political unrest while I was living overseas. We lived with bags by the door ready to go in case we needed to get out.
I found out in 2008 I had PTSD, complex PTSD, but I think the diagnosis should have probably been made when I was 14 years old.
I was raped, and as a result, I live with PTSD.
The civil war in Lebanon broke out in 1975. I was only 17 years old. I lived through that for about 12 years.
As it kind of sunk in, I started to feel really guilty because I had always associated PTSD with people who had been to war, and I just didn't think I deserved it.
The PTSD triggers, they ambush you. You don't know when it's gonna come. It's sort of the unknown. Every day you wake up and you don't know if you're going to have a trigger today.
And I want to just like stop this for a sec and explain that this is what is truly meant by the word trigger. It's something that can trigger a flashback or trigger other symptoms of PTSD for people. And unfortunately, just like we talked about last time with OCD, this has become like a throwaway word in our culture. Like, oh, did that trigger you? When for people who live with PTSD, it's a very real thing.
Was at a movie, and there's a part where this woman got trapped in a car. I had a serious panic attack.
There was a song that was talking about like shooting and armed robbery, and just hearing that song, like, that was all it took.
Something happened when I was 13, and when my trigger happens, in that moment, I am 13.
Usually the sounds of jet planes overhead would trigger off the memory for me of those days. It would make me feel weak in the legs, and my memory will go back to that time trying to look after my children when they were little and protect them. Yeah, all I had to do is hear a jet plane, and that's where my mind will go.
At times, it has literally felt like I'm dying. You feel like you're never gonna get past this. One of the things that's helped me a lot was group therapy. This happens to more people than you think.
Start to have a conversation with this.
And one thing I'll say is that you can do like structured group therapy where you're doing something like a cognitive therapy or a interpersonal therapy for PTSD, or you can also just have what are called process groups where it's support with a mental health professional there. And I've had experience working with both.
thing that you have.
I did counseling for 2 years in college, and it felt like that got my life into a pretty manageable place.
I am trying to build up the courage to attend a support group.
I would have these days where you're just like, you know, there's nothing I can do to do anything that you're supposed to do. In group therapy, someone called it a lost day. It's such a simple thing, but putting the words lost day to those days helped me like overcome.
And I think accepting that is really important, and just being like, it's okay to like freak out and just be like, oh, this is scary, like, because it's scary.
And don't ever tell them to get over it because it's extremely painful.
It takes practice and it takes patience and it takes faith. You have to know that the fact that you've been through something so traumatic and you're here, you are much stronger than you think you are.
Don't feel guilty when you have a good day.
Give yourself time to heal.
You can't judge yourself for it.
It'll never be the same, but it can get better, and it's worth whatever it's gonna take. You can have a better life.
There is a light at the end of the tunnel. You just got to find the right thing that works for you.
And getting help is not a sign of weakness. It takes a lot of strength and a lot of courage, and you deserve the happiness that comes with getting better.
My name is Kate.
My name is Tammy.
My name is Kirk, and I live with PTSD.
So again, some lived experiences there, what it's like to actually live with this diagnosis of PTSD. If you mind flicking that back on, thank you much. So I have lots of stats about PTSD, and you'll notice that some are contradictory. Not everybody reports their trauma. Not everybody seeks help, right? And so sometimes, depending on the type of study we're doing, we miss folks, right? So the lifetime prevalence for at least one traumatic event is about 50% for women and 60% for men. And approximately 7 to 9% of the general population will meet criteria for PTSD during their lifetime. The ratio of women to men is about 2 to 1. And I'll kind of explain why that is on some of the following slides. So after trauma, 20% of women and 8% of men develop disorders. We tend to think of combat, as you heard the one woman talk about, but we know that natural disasters, car accidents, abuse, victimization are more likely to cause disorders, and in particular, some of these. So in general, if you experience a trauma, about 8 to 10% of people will develop PTSD. If you're wounded in combat, that shoots up to 20% of people. If you've been raped or sexually assaulted, it's about half of people will develop PTSD. And if you're a prisoner of war, about half of people will develop PTSD. So I just want to like take a minute and look at those statistics side by side, that sexual assault is as damaging as being a prisoner of war, because it's such a intense autonomy and bodily violation. That's essentially the worst crime you can survive. And then for Vietnam vets, those who have repeated high levels of combat exposure, is about 60% of them that have developed PTSD. Some other rates of just experiencing traumatic events. So, you know, tragic death of a loved one, physical assault, fire, but about 70% of people have experienced some sort of traumatic event. And I saw a more recent statistic, and I think it was like 65. So like it hasn't really changed. So MVA here means motor vehicle accident. Unfortunately, they're one of the most common things people experience. So they're one of the most common things to result in PTSD. And combat and sexual abuse and assault. So disasters, tornadoes, floods, earthquakes, fires, tsunamis, physical, emotional, sexual abuse, combat and war-related traumas. Once upon a time, this was called shell shock or combat fatigue syndrome. And then I mentioned car accidents and sudden death of loved ones being one of the most common that folks experience. So following natural or accidental disasters, civilian traumas have been implicated in stress disorders at least 10 times as often as combat trauma, perhaps just because more people experience it. For example, as many as 1/3 of car accident victims may develop PTSD within a year of the accident. Types of disasters can also include traffic accidents, weather, hurricanes, earthquakes, airplane crashes. For example, something like Hurricane Katrina, right, caused many people to develop PTSD due to the fright, not only of experiencing the hurricane itself, but the aftermath. The city being flooded, people dying and being displaced, people who were sheltering in place at, I can't remember the name of their sports complex. The conditions there were horrible in terms of access to food and sanitary. Like toilets overflowed and that sort of thing. Sexual assault, I'm going to talk about a little more because unfortunately it's something that is very common for people of all genders. We tend to think of it as just something women experience, but it's not. And people who have been abused, victimized, or terrorized often experience lingering stress symptoms, whether or not they fully would be diagnosable with PTSD. So again, sexual assault or rape is unfortunately common. About 1 in 7 women is raped at some point during her life. I think, sometimes I've seen it's almost as high for men. I know for college students, it's like 1 in 4 or 1 in 5 for women, about 1 in 7 or 8 for men. For American men in general, 1 in 33. The psychological impact is immediate and may be long lasting. And one study found that 94% of sexual assault survivors developed acute stress disorder within 12 days after the assault. So not all of them will go on to get PTSD, but it's certainly something that profoundly affects you. It's also common among those who were either sexually or physically abused as a child. And many, regardless of gender, regardless of, who assaulted you, who you are, don't receive the care that they need. So 1 out of every 6 American women has been a victim of an attempted or completed rape in her lifetime. 17.7 million American women have been victims of attempted or completed rape. And college women are 4 times more likely to be assaulted. As I just mentioned, about 3% of American men, or 1 in 33, have experienced an attempted or completed rape in their lifetime. And in 2003, 1 in every 10 rape victims was male. That being said, we know the numbers are high among trans, non-binary, gender fluid individuals. But unfortunately, in a lot of especially large-scale studies, you're excluded if you fall into one of those categories because there are just boxes for male and female. So we need more research about how many are experiencing it and what the implications are. So in terms of sexual assaults that happen to students like yourself, about 95% of those attacks go unreported, regardless of your gender. About 20 to 25%, again, that 1 in 4 or 1 in 5 women will be raped or experience attempted rape during their college career. And 90% of women know the person who sexually assaulted them. So there's this myth that it's someone in the bushes, and it's typically someone you know. 42% of college women who are raped don't only not report it, they don't tell anyone about it. Not their closest friends, no one. We know that more rapes are happening than are reported because 10 times more sexual assaults are reported to crisis lines than are to the police. There are lots of implications for your health. About 40% of survivors develop STDs as a result of being sexually assaulted. Most of the time, your rapist is not stopping to put on a condom, right? 80% of rape victims suffer chronic physical or psychological problems over time. 13 times as many rape survivors attempt to die by suicide than people who have not been sexually assaulted. Rape survivors are 6 times more likely to attempt suicide than victims of other crimes. And 20 to 50% of sexual assault survivors seek mental health treatment. That's a big range, right? But it's still only a quarter to half. And why this is such a big range, just because again, we don't know how many people are being assaulted, because most people don't tell anyone. Victims or survivors of sexual assault are 3 times more likely to suffer from depression, 6 times more likely to suffer from PTSD, 13 times more likely to abuse alcohol, 26 times more likely to abuse drugs, and 4 times more likely to even experience suicidal ideation. So again, physical and mental health consequences. Again, wide range, 50 to 95% of developing PTSD. It's so hard to study this because so many people don't come forward, don't want to ever talk about it. Female adolescent abuse survivors, so those who have been sexually abused, are more likely to develop eating disorders. About 18% of those who have experienced childhood sexual trauma binge and purge, for only 6% of non-abused girls, so that's 3 times as likely. About 30% of those who are survivors of childhood sexual abuse will use illegal drugs, compared to 13% of those who have never been abused. Girls who are sexually abused are 3 times more likely to suffer from any kind of psychiatric diagnosis, and 4 times more likely to suffer from drug and alcohol abuse in adulthood. And about 30% of sexual assault survivors contemplate suicide. In terms of implications for your actual college career, in nearly every case, the survivors' victims can't perform at the same academic levels that they did prior to the attack. Sexual assault sometimes causes students to be unable to carry a normal class load, and they may miss classes frequently, which, depending on the class, may penalize them. Student victims regularly withdraw from courses altogether, just stop going to college. In more traumatic incidents, victims will often leave the school until they recover. Sometimes they'll transfer to another college, sometimes they just won't go back. So combat. So again, we've known since at least World War I that soldiers experienced distress during combat, which is called shell shock or combat fatigue. This is a little late, actually. During like the Revolutionary and Civil Wars in the US, for example, people acknowledged things that looked like PTSD symptoms. They just didn't necessarily have a term for it. Post-Vietnam War, clinicians discovered that soldiers also experienced psychological distress after combat. And about 30% of Vietnam combat veterans suffered acute or PTSD, and an initial 22% had some symptoms, even if they weren't diagnosable, and at least 10% are still experiencing problems. Again, many of those are folks who didn't seek help until more recently. Unfortunately, terrorism is something that just inherent in its name, right? Is meant to cause fear. So you're susceptible if you're a victim of terrorism, or if you just live under the threat of terrorism. And I often use September 11th just because it's so seared in my mind. I was a sophomore in college when September 11th happened. We have very high rates of stress reactions following September 11th. So about 44% of the US population, and it goes up to 61% if people live within 100 miles of New York City in particular. And a high incidence of PTSD. So in New York in particular, it's on 9% of adults, 8% of college students, and 11% of kids meeting symptoms of PTSD. And in the US in general, the numbers were pretty high, 4%, 7%, 4%. People who were staff members at the Pentagon, 23% of them developed PTSD. A lot of times people forget the Pentagon plane. It did hit the Pentagon building directly. Imagine working in the building that's like one of the biggest fortresses in the world and it's about defense, right? There's a lot of, I'm sure, complicated feelings related to that. So what causes stress disorders? Because we've been saying all these percentages, but we know that all these percentages mean that not everybody who experiences a trauma develops PTSD. So trauma is obviously necessary. You've got to have that criterion A event, but it's not sufficient. Not everyone who experiences a trauma will develop PTSD or even ASD. There's a whole bunch of other factors that come into play, and we're going to give each of these its own slide as we go through. So first thing we're going to talk about is biological and genetic factors. So traumatic events trigger physical changes in the brain and the body that may lead to severe stress reactions or disorders. And it seems like there might be some abnormal norepinephrine and cortisol activity. Cortisol is the stress hormones, or that really shouldn't surprise us, right? They've done a twin study with Vietnam vets. And identical twins who were both deployed to Vietnam were much more likely to both develop PTSD than fraternal twins who were both deployed to Vietnam. We always, of course, have to take into account that this might also be partially due to shared environmental factors. Although it becomes stronger when you're of age to go to war, right? Because oftentimes you're like left home by that point. All right, so next I have a really interesting study where they've done some brain scan studies looking at soldiers and children who are survivors of childhood sexual abuse.
That half of all mental health problems begin in childhood before the age of 14. And one of the things we're looking at is how experiences of early adversity, such as domestic violence and maltreatment, can lead to changes in brain structure and function that can embed long-term vulnerability to mental health problems. It's something we're calling latent vulnerability. Those who had been exposed to maltreatment and domestic violence showed heightened patterns of activation in those brain regions related to threat vigilance and threat detection. And what was striking is that we see the same pattern in other studies done by other groups where they have looked at soldiers before and after combat. And that might help both the soldiers and the children function in those environments, but the difficulty is that it may also embed long-term vulnerability. We believe it is reversible. We know that many children who experience abuse and neglect and domestic violence have a resilient and positive outcome, and we expect that their brain will change and respond to positive emotional experiences such as social support and being in a secure and safe environment.
So that last part is really important. Our brains have plasticity and adaptivity that we see throughout our lives. And so it's possible to undo these changes. One of the things we'll talk about when we talk about eating disorders after break is that if you have anorexia nervosa, one of the things that can happen is your body has eaten everything else it can, your body fat, your muscles, so it eats your brain, basically. And when you recover from anorexia, you actually regain that brain mass. So again, that's positive, right? But it shows that there are actually brain changes. In terms of personality, we know that some of the risk factors are already being someone who's anxious, right? Pre-existing high anxiety, a history of any kind of psychological issues, having that negative worldview, so who are depressed, things along those lines. But there are protective factors, and you mentioned resiliency. One of my best friends in grad school did her master's thesis looking at resilience in PTSD. And she actually found that people who were more resilient were much more likely to lose their symptoms, which is great, not be diagnosable anymore. They can carry on their lives with fortitude, control, and commitment. But I do have to say, sometimes when we talk about stuff like this, it comes across shady, like, oh, you don't have that. What's wrong with you? And I want to emphasize, no. People who have PTSD, none of this is their fault. In terms of childhood experiences, living in poverty is a risk factor for developing PTSD because we know that that's a high stress environment. Having a history of any kind of psychological disorders within the family. Again, there might be some genetic vulnerability that's shared there. If you've already experienced trauma, experience of assault, abuse, or catastrophe at an early age. My client I mentioned a few minutes ago, who would sometimes have flashbacks while she was having consensual sex, she had also been sexually abused as a child. So of course she developed PTSD when she was assaulted in the military. And then being younger than 10 when your parents separated or divorced, this is if it's contentious. But what they found is that once the parents do separate, especially if it's contentious, it's actually better for the kids in the long run. In terms of social support, if you have weak social support, so you don't have a lot of friends or family you can lean on, you're more likely to develop PTSD, and it takes longer to not be diagnosable. And this we see in particular in combat vets. And people who do have that social support, who feel loved and cared for, are much more likely to recover, and we see this especially in survivors of sexual assault. The more severe the trauma and the more direct your exposure to it, the greater the likelihood you have of developing acute stress or post-traumatic stress disorder. Especially risky are mutilation and severe injury, as we've mentioned previously, sexual assault, and witnessing the death or injury of others. Behaviorism learning theory talks about it using classical conditioning, the idea that the traumatic stressor was an unconditioned stimulus, and that starts to get involved or get associated with various neutral or conditioned stimuli in your life. So again, I was in a motor vehicle accident. I wasn't, but I'm trying to come up with a scenario. Someone was in a motor vehicle accident, on Virginia Beach Boulevard at Town Center. They might not go there anymore because it's reminding them of it. And then in terms of cognitive and psychodynamic theory, we will see throughout the middle of this semester, there are several times where these agree, which feels a little weird, right? Because we tend to think of them as pretty disparate. But both talk about the avoidance or inability to integrate the event, leading to PTSD, that this might be partially a disorder of emotion processing or lack thereof. So this is just a nice chart of some of those causes of PTSD. We also know that PTSD itself affects your physical health. So people who are survivors of any sort of traumatic event, particularly those who develop PTSD, have increased health utilization. That means they're going into the health system more often. They have an increased number of illnesses. We know that stress is related to healing in the body. And it's harder for us to fight things off when we have high levels of stress. I don't remember if I mentioned this study in here yet or not, but it was a really interesting study I heard about while I was in grad school, where they consensually put little cuts on med students' tongues while they did it like in a normal time of the semester than during midterms. And the cut actually took longer to heal during midterms because of the stress response. Gastrointestinal problems, we know a lot of things like, for example, irritable bowel syndrome are linked to stress. Cardiovascular problems. We know that heart and blood pressure issues are linked to stress. Headaches, particularly tension headaches. But again, you have to sort of think about the other types of things these might have been associated with. So again, a lot of the combat vets from Iraq and Afghanistan also had traumatic brain injuries. So they get migraines in addition. Problems with sleep, we've already mentioned. TMJ is a pain disorder throughout the jaw muscles. And then for women, particularly those who have been sexually assaulted, pelvic pain. Other associated problems, just feeling senses of despair and hopelessness, which, as we learned in our suicide chapter, are never great things to be experiencing. Loss of important beliefs. Some people who've been very religious will abandon their faith. Anger and aggressive behavior towards yourself or towards others around you. You don't understand. How could you ever understand? Some people who've never been abusive before will become abusive to their spouse. Self-blame, guilt, and shame. These are some of the hardest symptoms that really keep people stuck in PTSD. Problems in relationships with others, social isolation, problems with identity. Who am I if I'm this quote unquote weak person who has PTSD? And problems with self-esteem. So how do we treat PTSD? Well, it's hard, but it's very doable, which is really great. So these folks tend to, unfortunately, without treatment, PTSD symptoms will last about 5.5 years. With treatment, they're saying 3 years. I'm just trying not to sound grumpy. Okay. These are probably treatments that are not empirically supported for PTSD, because modern empirically supported treatments for PTSD actually, like they can reduce symptoms in about 6 months. So, unfortunately, not everyone believes in or is trained in empirically supported treatments. And so, unintentionally, well-meaning therapists and counselors can keep people in their PTSD by not treating them with these empirically supported methods. And treatment type will depend a little bit on the type of trauma, and particularly the severity and whether or not it's a one-off or repeated trauma. And the general goals of treatment are to end lingering stress reactions, to gain perspective on your traumatic experience, and try to return to constructive living. So, psychological treatment of PTSD, we really do tend to gravitate more towards therapies that come out of the cognitive behavioral perspective at this point in time. These are a lot of what is empirically supported. So cognitive behavioral treatment can involve either graduated or abrupt imaginal exposure. Imaginal exposure is where you have the person retell their story of their trauma or pretend they're back in the moment with their trauma. You increase positive coping skills and social support. And cognitive behavioral therapies are highly effective. And to be perfectly honest, were I ever to go back to doing clinical work, I would want to do trauma therapy. I loved working with clients with eating disorders. It's really hard to get them to change. Like these empirically supported treatments that are supposed to last 20 weeks, 2 years. The person still wouldn't want to change. With the folks with PTSD working through the empirically supported treatment, you saw change very quickly and you saw them benefit from it. So I don't ever plan to go back to clinical work, but if I did, I'd probably want to work at a VA in the PTSD unit. And in particular, when I was on my internship year, I worked quite a bit with survivors of military sexual trauma. So these are veterans who have been sexually assaulted by fellow service members. Not the enemy combatant, which I think is what a lot of times people think of. Just because, again, that work was hard, but it was rewarding because you got to see the changes. You can also do medical treatment of PTSD, SSRIs in particular, but also other anti-anxiety medications can be helpful. And oftentimes my clients, so we would work closely with the psychiatrist on the PTSD unit, and oftentimes my clients would be on a cocktail of different medications to help treat the PTSD, but also because a lot of them would also have depression or other things as well. So as you can see, for combat vets, they often are on some sort of or some combination of anti-anxiety and antidepressant medications. They also engage in the behavioral exposure therapy. We're going to talk about some of these different types of therapies. I don't know if we're going to get to them today or if we'll get to them after break. But in particular, these reduce specific symptoms and increase overall adjustment. These use flooding. So remember we talked about like systematic desensitization where you kind of gradually work up, and flooding where you just like put someone in the elevator and hit the button. These are flooding, but for your trauma. One of the therapies that has some empirical support is EMDR, or eye movement desensitization and reprocessing. This is essentially the same type of exposure you do in other behavioral exposure therapies, but you have them do some sort of physiological thing at the same time. When it started, it was eye movements, moving your eyes in a certain way. Now I think you like hold things in your hands and they give you like a vibration. I'm not trained at this, so this is only talking to other people I know who've been through it. You know, again, it works. I do have to say for the eye movements, there were studies of people who were blind that it still worked with. So it was like, is it the eye movements? In my opinion, again, because this is what I'm trained in, it's probably the exposure component. And that the EMDR might make that more palatable to people. And if that makes more people get help, awesome. Let's roll with EMDR, right? Insight therapy involves bringing out deep-seating feelings, creating acceptance and lessening guilt. And this can be used in family or group formats or what are called RAP groups. And they're, again, these treatments are often used in combination. So, you know, any given client I was seeing would typically be an individual therapy with me, perhaps like the group process therapy, and also seeing a psychiatrist. One of the interesting things that was developed is psychological debriefing. And this is a form of crisis intervention that has victims of trauma talk extensively about their feelings and reactions within days of the traumatic incident. And they typically do this for large-scale disasters, natural disasters, terrorist attacks, things along those lines. And they try to normalize responses to the disaster, encourage expressions of emotions like anger, anxiety, frustration. They teach them self-help skills, and then they provide them referrals for more extensive follow-up therapy. We see this not only in, say, like combat vets, but relief workers. So people who respond to a trauma are often themselves traumatized by it. Traumatized, there we go. However, research on this intervention has called into question its effectiveness, particularly whether it is useful or whether it makes things worse to try to process them so soon after the trauma, and particularly if you're going to have to like go back and work again the next day. Now, in terms of treatment for sexual assault survivors, cognitive behavioral therapy and its derivations really are the gold standard here. And some of them are more cognitive, some are more behavioral. One is called stress inoculation training, and it focuses more on the behavioral. So focusing in on things like muscle relaxation, breathing control, role playing, thought stopping, trying to stop those intrusive thoughts, and guided self-dialogue where they label negative irrational thoughts and substitute more adaptive skill self-verbalization. So very similar to other types of cognitive therapy we've talked about. Exposure techniques, again, these imaginal techniques where the trauma scene is relived in their imagination out loud and in the present tense with detail included. And then cognitive processing therapy includes multiple components that we'll get to on the next slide. And then EMDR has been used here as well. So cognitive processing therapy, or CPT, is something I was extensively trained in when I was at the VA. This is very effective in my opinion. And we did it in both individual and group formats. Actually, one of the most interesting things I did while on the PTSD unit was help with a men's sexual assault survivor group. And most of these men had been sexually assaulted by fellow male soldiers. So lots of feelings of guilt, lots of feelings of inadequacy or not being manly enough. But we did this with women individually and in group as well. So it's got 12 structured sessions. They're about 50 to 60 minutes. You start like you would with any type of therapy with a diagnostic assessment. And then your first session really focuses on education about PTSD and information processing theory. One of the things we talk about with our clients is like people try to avoid thinking about their trauma. And the analogy we use is, let's say you get a bill and you're like, I can't pay this right now. And you just like shove it in your desk drawer. So you don't have to think about it right then, but the next time you go to get a pen, you're like, I didn't pay that bill, right? And the same thing can happen with your trauma. If you try not to think about it and avoid it, it can come up and like sort of sneak up on you in all kinds of ways. And so there's also one of the next things you do is exposure to the trauma. You have them at home write out what happened to them and read it in session. And you have them do that twice. And the rest of therapy focuses more on sort of traditional CBT techniques, but addressing specific, what they call stuck points, sticking points for people with especially sexual assault trauma, beliefs about themselves, the others, and the world. And as you can see here, there are 5 main areas: safety, trusting other people and themselves, power, self-esteem, and intimacy. So learning to trust other people again. So I have a brief video talking a little bit about CPT, and this is from the VA. So when I was at the VA in 2009, 2010, they were doing a nationwide rollout of CPT, prolonged exposure, which is the next one we'll talk about, and then CBT for depression, where they were saying everybody should be doing these because these have a lot of research that shows they work.
A traumatic event can change the way you think about yourself and the world. You might think you're to blame for what happened or believe you don't deserve to be happy. You may start to believe the world is unsafe. Doing things like going to a grocery store or restaurant may seem too dangerous. These kinds of thoughts are common in people with post-traumatic stress disorder or PTSD. They're called stuck points. They keep you stuck in your PTSD and cause you to miss out on the people, places, or activities you used to enjoy. So how do you get unstuck? Cognitive Processing Therapy, or CPT, is a PTSD treatment that can help you break the negative thinking that's holding you back. It's based on the idea that our thoughts affect how we feel and how we act. In CPT, you and your therapist will talk about how your negative thoughts about the trauma, those stuck points, have changed you, how safe and in control you feel, how much you trust yourself and others, and even your sense of self-worth. You'll practice a strategy to change or challenge your stuck points. PTSD can make you jump to negative conclusions, but there may be other ways to think about things that are more accurate and less upsetting. Imagine you're driving down the highway and someone swerves in front of you. You might blow up at the driver. What a jerk. But what if he was racing to the hospital or having a panic attack and rushing to get off the road? If you considered these possibilities, you might not feel as angry. The bottom line, small changes in thinking can have a big impact on how you feel. Some people find that writing about their trauma helps them change upsetting thoughts and feelings. You and your therapist can decide whether or not this is right for you. CPT works just as well either way. You can also choose to meet with your therapist one-on-one or in a group with others who have PTSD. CPT is evidence-based, meaning it's been shown to work in multiple research studies. And it doesn't take years. In fact, CPT usually takes about 3 months of weekly visits. CPT can help you get unstuck, freeing you up to start enjoying the things you've been missing out on. Men and women, veterans and civilians can all benefit from CPT. If cognitive processing therapy sounds like it could be right for you, talk to your doctor about finding a CPT provider, or visit the National Center for PTSD website at www.pt
So the National Center for PTSD is based out of the VA in, I believe, Boston. I think that sounds right. And it is a research focused program, but also obviously provides a lot of treatments as well. Alrighty, so next up is prolonged exposure. Just checking we probably have time to talk about PE, then we'll talk about some of this other stuff after break. So prolonged exposure is flooding. So these are longer sessions, 90-minute sessions, 10 to 15 structured sessions. Again, you do a diagnostic assessment, you do education about PTSD, but also about learning theory. So some of the things we've talked about with avoidance and association with neutral stimuli. And then you do in vivo exposure and imaginal exposure. So the imaginal exposure, you have them write down and tell their story of their trauma over and over and over. So for the whole 90 minutes, they just tell their traumatic story over and over, and they record it and they listen to it at home. And the idea here is about, we are going to desensitize you. This is not that bill in the drawer anymore. This is like, you are facing your fears. So and then in vivo exposure is, we would then also encourage them to go out and do exposures to things they're afraid of. You're afraid to go to Walmart when it's busy. You're going to go to Walmart at 5 p.m. and see how it goes, right? And you give them skills very similar to phobia therapy. Here's relaxation skills, things along those lines. So you're prepared to do that. Again, another VA video here.
If you have post-traumatic stress disorder or PTSD, it's common to feel like there are places or situations that are unsafe. It may seem like the best option is to avoid them, staying away from people or places that feel dangerous or reminders of a traumatic event. As a result, you may develop I can't rules. I can't leave the house at night. I can't trust anyone. I can't handle crowds. But these rules won't help you overcome PTSD. So how do you learn to say I can? Prolonged exposure, or PE, is a treatment for PTSD that helps you do safe things you've been avoiding. In PE, you and your therapist will practice exposure, meaning you'll work to approach things you've steered clear of since the event. You have to challenge your I can't rules to prove to yourself that you can. Remember when you were learning to swim or even drive a car? It was challenging at first, but got easier with practice. Exposure gets easier with time. With your therapist, you'll take steps to do the things that have been hard for you at your own pace. So if you're avoiding the grocery store, you might start by going when it isn't crowded, maybe bringing a family member along. You'll eventually practice going on your own, perhaps even during peak hours. With practice, you'll find that you can handle it.
So those are those.
You'll also talk through the details of your traumatic event in a safe, gradual way with your therapist. Closing your eyes can help you concentrate. Retelling the event may sound like the last thing you want to do, but it helps with emotions like anger, guilt, and sadness. You'll listen to a recorded version at home too. After a few months, you'll find that you can talk about your trauma.
I'm just like laughing to myself because, okay, when my roommate in grad school was learning to do this, her specialty was PTSD, they would give them audio tapes to go home and listen to. And now, of course, you just record it on their phone and have them listen to it. It's just like hilarious to think like how much technology has advanced in the past 20 years.
Without feeling so overwhelmed. Prolonged exposure doesn't erase your trauma, but it can help you keep your traumatic experience from getting in the way of living your life. PE doesn't require you to take any medications. With your therapist's help, you'll follow a step-by-step program for about 3 months. Most people who complete PE show noticeable improvement in their symptoms, and many no longer have PTSD. Prolonged exposure works well for both men and women, and it's evidence-based, which means PE has been proven to work in multiple research studies. If prolonged exposure sounds like it could be right for you, talk to your doctor about finding a PE provider, or visit the National...
So again, finding someone who specializes in that. All right, so we'll talk more about just basic stress related things after break. Everyone enjoy your break. Try to take care of yourselves. Give yourself some downtime. And I'll look forward to seeing y'all in a week and a half.